Morning, Sonia.
Good morning, Maya. How are you today?
Oh my God, I'm fighting something off my uvula. Like the dangling thing in my throat is so swollen. It's awful.
Oh,
Like resting on my tongue. I had to sleep on my side, otherwise it was like choking me. I'm like, what is going on?
How long has it been feeling like that?
So I was actually in Baltimore and on my flight home on like late Saturday night, the symptoms started, and then Sunday was awful.
Mm.
Yesterday was a little bit better. Today's a little bit better. So I'm I never get sick, so it's just no fun.
Yeah. And you've got family in Baltimore, is that right?
I do. I was born and raised in Baltimore, so pretty much everyone's there. My in-laws are there. My husband, all of my family. I have a new baby nephew, so I went to visit.
Oh, okay.
So it was lovely, and my grandma just turned 92, so it was a big family affair, and we ended up taking a family trip to DC. So and we went to museums and just touristy stuff for my kids. It was fun.
Yeah, that's good.
We have spring break much earlier in Florida than. Do you have any kids or not yet?
No, I don't have any children. I have nephews. So
Nice.
they especially the oldest one, it is in my pocket like a child. So
Yeah.
yeah. So yeah, I was telling my mom he has prom in a couple of weeks, and had gone to pick up something for he wanted a bow tie for prom, a bow tie and a pocket square. So I gone to pick that up for him yesterday, and this has been quite an expensive process, but this is once in a lifetime. So we will see. Mm-mm. So we had our spring break last week also. We tend to have spring breaks.
Oh, yours is early.
I was gonna say we tend to have them a bit early. Guess since we start so early, we start the first um of August. So
Okay, so it's same as us down in Florida.
hmm
Because up north, it's like they started after Labor Day. It's so different.
right, right. Hi, Ashley.
Morning.
Hey, Ashley.
How was your trip to
It was so
Baltimore?
nice. I was just telling Sonia it was family filled. Did a lot of hiking, which is we don't get that in Florida. I mean, everything is flat here. And we went to DC and did went to the National Museum of Natural Science, which was super
Oh,
cool. And
awesome.
I mean,
Oh
we
my
had such
goodness.
a
It was
fun time.
beautiful weather this weekend. I'm sure DC was crazy busy though.
It actually was so we went to DC on Thursday. We figured if we caught it
Oh,
during the week, we would be able to
perfect.
miss some of the traffic, which was good. It was
Yes.
freezing. We got in on Tuesday, and Tuesday and Wednesday was freezing.
Oh
Like
yeah, no, it
literally,
was
I'm
so
like,
cold.
what is this weather? By the time we left Saturday, it was like 78 degrees and beautiful.
I know, like Saturday, Sunday, and yesterday was so beautiful here. And then my poor son was like, it's so cold. This
No.
morning I'm like, I know this is spring in Maryland. I don't know what to say to you. Like, it's how it goes. Like, one day it's 80 and one day it's 40. Like, this is what we have to live with.
Get used to
I know. I'm like, this is our life. I'm sorry.
it.
So
But
did
yeah,
you all moved to Baltimore, or are you all? No, but you've always been in Baltimore though, right?
I have. And I work in Philadelphia now, really just to complicate things. But Philly and Baltimore are not very far from one another. So I take the train um up to Philly. So after this, I'm gonna jump on a train and get to work a little later. But yeah.
My brother and sister-in-law, they live in Philly and they came in on Friday. I felt so bad because the traffic was horrendous, but they came in so we could have a literally all the cousins together. It was a fun group.
That's so nice. Yeah, no, I don't drive. I don't deal with that. Yeah. No traffic for me.
So real quick, I've got a couple people in the waiting room. Ashley, were you going to share your slides, or did you want me to?
I can share my slides.
Okay, great. So I will not do that and let everyone in, in, from the, in, from the waiting room.
Morning, everyone.
Super hot. Very, very hot.
It's 9 o'clock, so we'll just give a few more minutes while everybody straggles in, and then I'll let Sonia do the housekeeping before handing it over to Ashley. Sonia, do you want to start with housekeeping stuff, and then we'll be able to get Ashley starting around 9:05?
Sounds good. All right.
Awesome.
Welcome, everyone. So we have our Echo housekeeping, asking that you keep your cameras on when you speak, having your webcam positioned effectively, muting the microphone when you're not speaking, and then respecting our private health information. We have the UAB accreditation and EOE statements. Ashley does not have any disclosures for us this morning. And then you have the QR code that's here on the screen for you to scan for your credits. You can also click on the link in the chat box. And then just a couple of announcements. We have our upcoming Sapport Echoes. We have as you see here on the screen, emergencies in sickle cell, using social media to bridge health disparities, and then health and hearing impairment in sickle cell. So some really good presentations coming up in the next few sessions. And then just really, really quickly, a couple more announcements. We have 2 scholarship opportunities for our warriors coming up with a deadline of May 1st. I will get these out in the follow-up email. These are for our sickle cell warriors. And then lastly, the Memorial Sloan Kettering Advances in Treatment of Sickle Cell Disease coming up May 7th and 8th. That is virtual.
Awesome. Thank you so much for including my scholarships. That was a fun surprise. So for those who don't know, I have a nonprofit called Heme Foundation, Health Equity Matters, and I'm just health equity is my passion. Sickle cell is my passion, and I've just found ways to keep furthering my mission and making my impact. So the application process is super straightforward. There's 2, one for high school students who are making an impact in their community. The other is for individuals in college or advancing their degree. It's a very straightforward application, a short writing prompt, like 500 words, 1 letter of reference, and just proof of diagnosis. So with that, I'm going to introduce Ashley, who I feel like doesn't even need an introduction. I mean, you're famous in the sickle cell world, but she is an advanced practice nurse practitioner. She's the nurse manager of the Division of Hematology at Thomas Jefferson, and she joined that team last fall. Prior to that, she was the APP manager and program manager for the Sickle Cell Center for the Adults at Johns Hopkins. She is the co-director of the Sapport Education Program, and she co-facilitates the Sapport Echo sessions. So without further ado, let's call up Ashley, and she'll be presenting today on traveling with sickle cell.
Thank you, Maya. I don't feel like I'm as famous as you, though.
I don't feel famous, so we're on the same page.
Okay. Do you see my big screen? Or is this the presenter view? This is the good one? Okay, great. Perfect. Thank you so much for having me today. So I'm going to talk about travel considerations in sickle cell disease. We are starting to get warmer weather and hopefully people traveling over the summertime. So these are just some things to consider for our patients. I do have some disclosures, but none that are relevant to this talk today. And so I'm going to talk today about the potential complications related to travel for persons living with sickle cell disease, identify some best practices and considerations for optimizing patients for travel, talk about infection prevention strategies and patient education, and talk about also vaso-occlusive events and how we can prevent those, and then also strategies around travel and if patients have vaso-occlusive events during that time. So what does the evidence say? So in much of what we do, there's really limited evidence. And I gave this talk a couple of years ago, and this is still the most recent, this article from Willen in 2014, which was a summarization of research of 7 different studies. There were a total of 349 patients, and their ages ranged really drastically, right, from 2 months to 62 years. And then there was a difference between international travel as well as domestic travel. And you can see here, although it's not the perfect image from this article from Willen, where the travel was throughout the world. And most of it was in African countries, although there were some within the United States and also in outside countries in Europe and the West Indies. And it looked at the duration of travel as well as the complications. And we'll go through those complications that they saw, but are some of the things that we think about when our patients are getting ready to travel and go somewhere either domestically or internationally. The potential risks, I think most of you probably already have thought about this in caring for people with sickle cell disease. So vaso-occlusive events is always at the top of my mind for patients. Related to if they're going to be dehydrated, the high altitude, especially if they're going to be using air travel, the risk of diarrheal illness, depending on the country of origin that they're going to, and access to clean drinking water, other infections that can occur depending on which country you're traveling to. This was, right this talk was different a couple of years ago. Thinking about infection risk really was like focused on COVID and COVID cases. And now that paradigm has changed a little bit as we are now in 2025, but there's still other considerations and other risk factors for other types of infections to be aware of. Venous thromboembolisms, so right, people with sickle cell disease, right, are a hypercoagulable state. And so with travel, especially airplane travel, does that increase the risk for our patients? Or long car rides, right? That could also increase the risk. So having that in mind, splenic sequestration, mainly related to the high altitude, especially if they're doing airplane travel. In that study from Willen, they did see some cases of splenic sequestration, but they also saw diarrheal illness, mainly related to areas that potentially had issues with clean drinking water. So these are all some considerations and potential risks for our patients as they travel. So the pre-travel assessment, and when I see a patient in clinic that's telling me that they're traveling, I really think through the process of where they may be going, but also what disease modifying therapy are they taking? Are they on any disease modifying therapy? Have we made any recent adjustments to their hydroxyurea? Or are they on chronic transfusion therapy? So for patients that are on chronic transfusion therapy, okay, let me try to plan maybe if they're going to go for an extended period of time, make sure they're not, leaving, 2 weeks after their exchange, and now they're going to go for 4 weeks. That could potentially put them at risk. Figuring out if the patients have other comorbid conditions that might put them at high risk of travel. Have they have a history of clot? Do they have pulmonary hypertension? Do they have CHF? So thinking through what other complications may put them at higher risk of travel and how to best optimize them. Where are they traveling and how long are they traveling for? What's that travel time going to look like as it corresponds to their disease modifying therapy? But also the country of origin also is important to understand as we think about countries that are endemic in malaria, like are they going to need malaria prophylaxis, or are there other infections that are occurring in that specific region? Will they have access to a sickle cell care center or a sickle cell specialist? Where is the closest sickle cell specialist? So I try to think about, especially domestically, if my patients are traveling and they're going for long periods of times, I think about, okay, well, where is the closest, sickle cell center, closest sickle cell expert that if they were to get in trouble and have a vaso-occlusive event, where would I want them to go? And where would I maybe, try to avoid maybe a smaller hospital that doesn't have the expertise? Do they have insurance coverage, and what type of insurance coverage do they have? So for private insurers, this might be a little bit easier versus people that have Medicaid insurance. Certainly for patients that, go into an emergency room, or if they need to use an emergency room, that might not be an issue. But I had a patient that was actually going to Florida and had reached out to Maya and actually Dr. Unganchale about this patient, like, okay, if he's going to be in crisis, do you guys take this patient's insurance? And like, how could we potentially, if they needed this resource, could they use the resource? Do you guys take new patients or unestablished patients in your infusion center? So having some of those conversations too, to try to see if you can, have sort of a backup plan for the patients. Is the patient on chronic opioid therapy, or do they have any opioids at home? So I do have patients, right, that aren't on chronic opioid therapy that use opioids very infrequently, but if they're going to go for a longer period of time, I want to make sure that they actually have some pain medications on hand, just in case they have a crisis that could be managed at home. So planning, right, again, planning sort of for those vaso-occlusive events, making sure that they have medications for travel, ensuring that they have enough medications, which can sometimes be hard, especially if people are going to go for extended periods of time. Right, we can't really write 6 months of opioids, right, for a patient, but if they're going for a month, right, making sure that they have enough, making sure that they understand sort of what the emergency refill process may look like and what those restrictions may look like. So if they're going to another state, another country, and they run out of their medications, right, most of the times we're not going to be able to fill them because they're across state lines and related to licensure. So trying to plan ahead as much as possible. Timing of sort of the trip around around sort of opioid refills, we can always sort of go around that period to sort of within reason, right? Like you probably can't send, 6 months or a year of opioids for somebody, but for a month, you can sort of plan around their pickup schedule. Doing education on sort of travel restrictions as well, and for the patients that are able to really look up and see what those restrictions may be, making sure they have the proper documentation, especially if they're going out of the country. I've had some patients that have gone to different countries, and there are certain rules and documentation that has to be in place, especially for the controlled substances if they're bringing it with them, even though it's prescribed. Again, sort of identifying that closest sickle cell center and expert, identifying the closest emergency department, and maybe the emergency department that maybe is associated with the sickle cell expert. If they have insurance, we sort of talked about this, the types of insurance coverage. Could they be seen in an infusion center? Or are they going to have to go to an emergency room? Ensuring the patients have a copy of their patient-specific treatment plan, or have it in a place that multiple different centers across the country could potentially see. I think that might be a little bit of a dream state, because many of us have patient-specific treatment plans for our patients, but being able to see them, in different states and even different countries is challenging. A lot of times I give a patient a letter that has their opioid medications that they take, and also their patient-specific treatment plan, and then the number to our office, our on-call provider, right, so that they can call and say if they have questions or concerns about the patient. Where to find a sickle cell center. So I think, places like Echo are really nice because we get to know one another. We know where everybody is located, but the National Alliance of Sickle Cell Centers does have the sickle cell centers throughout the country and where they're located. And so I think this is a good place to start, especially if you have a patient that maybe is on the West Coast that's traveling to the East Coast, or vice versa, and where maybe a sickle cell expert center may be located. So even if they can't utilize the infusion center that may be there, at least if there is a sickle cell expert associated with that hospital, it would be nice. But you can see there are certainly areas throughout the country that maybe are more rural that don't have sickle cell experts located there. Again, sort of like utilizing Echo, but also the SCAPN network, I think, is really powerful. I've seen many times people have been like, I have a patient that's moving, or I have a patient that's traveling to this area. Who would be able to see this patient? And so I think these networks are really important to identifying if our patient's traveling or if they're moving, who they can be linked to see. Prevention of vaso-occlusive events, right? So this is really hard because there's so much limited evidence. And I think even limited evidence when it comes to even the management of VOE, so there's questions around, do we provide pre-travel hydration? Should we transfuse the patient beforehand? Should they get oxygen for travel? And these are really still big question marks that we don't really have a whole lot of evidence. I will say in practice with seeing patients, it's really patient specific when I use these metrics. I rarely will hydrate patients before travel, although if a patient's been like, I've done this before, this has really helped, and they've had maybe some other comorbid conditions and they are able to tolerate hydration, I may utilize this for patients. Transfusions I don't typically do for patients that aren't on chronic transfusion therapy, but I will say I did have a patient that was doing a really extensive travel, like over 20 hours of travel, and was going to be going for a longer period of time, that we did utilize this option and got a couple of transfusions over a couple of months, really just to try to optimize her for this long travel that was going to go to a remote place where she may not have access to care. Oxygen, so I've heard people to sort of talk about high altitude testing. Should we do high altitude testing in our patients? I think the evidence is still sort of up in the air and hasn't been studied, but something to consider for patients. I have had patients that have asked for oxygen on travel, where you're able to, a lot of times with the airline, you can provide some documentation. It's not always that clear, but mostly for patients that need oxygen, it's the easiest thing to do, because qualifying somebody that doesn't qualify for oxygen can be difficult. I have had patients that have felt really strongly about it and have had the means and have paid out of pocket for oxygen for travel. And so I haven't limited them because it doesn't seem like there's much risk associated with it, but sort of the benefit is still sort of up in the air. Having the good disease modifying therapy, making sure they have their medications, making sure you're timing your chronic transfusion therapy. If that is their disease modifying therapy is really important, especially for extended travel. Infection considerations are also really important and really dependent on where the patient is actually traveling, considering the patient is, if they're up to date with their vaccinations. The WHO has some travel guidance, and I have a link here which I can share, which I think is helpful, and some health topics associated with travel. The CDC still continues to have recommendations for vaccines and prophylaxis based on country. And so this is a link to the yellow book for travelers' health from CDC. It does talk about, sort of travelers' clinics. I think in my practice, it's been really difficult to get patients in to infectious disease or travel clinics. So in my experience, our team has been the ones that have done this. My landscape of a team is a little bit different now. And so we do have the resources of primary care that could assist us in this situation. But I think many times it's difficult to get patients into these travel clinics that are long periods of time, but making sure that they have adequate prophylaxis if they need it is, I think, the most important thing. The CDC does have travel advisories that are in levels from 1 to 4. So level 4 being avoiding all travel. This is the most recent guidance just from last month in March. So you can see there are no areas of level 3 or level 4 travel advisories, but there are several that are level 2 and level 1. So practicing enhanced precautions or normal sort of precautions, which is the level 1. Here's a list with the links of the current, just from last month's level 2 per the CDC. So you can see per country of region, different infectious processes. So Ebola in Uganda, there is still the global polio, and then diphtheria in Guinea. So there are, if you go onto the CDC website, it is really helpful, I think, depending on where the country of origin is going to be, and where potentially there may be an outbreak or an increased risk of transmission of different infections. Malaria is, I think, the biggest one that we think about in our patients, especially if they're doing any African travel. It is a tick-borne illness. It's not endemic to the US. In the WHO in 2023 estimated there were 263 million cases of malaria, and 597 deaths occurred in 83 countries. In 2025, 94% of the malaria cases were within the African region, and 95% of the deaths also occurred there, and 76% of them were children. I think this is sort of important to note that although people with sickle cell trait have this protection right against malaria, people with sickle cell disease can still get malaria, and they can actually get very sick from malaria. And I have seen at least 2 cases of patients that have been hospitalized related to malaria. In a cross-sectional study in Uganda that was actually published this year, it actually showed that sickle cell disease was one of those factors of readmission in children with sickle cell disease that also had malaria. So they're higher risk of complications as well. Malaria prophylaxis is really based on the country of origin and timing before travel. There is a link here, which I think is always so helpful, choosing a drug to prevent malaria that the CDC has, but they also have a malaria hotline and a website that is still in current use as I looked at the CDC website. So it looks like that resource is still available. And then they do have some documentation on some drug shortages as well. So I think it's a good place, at least to start, if a patient is doing travel to one of these areas that may be endemic in malaria. Willen did give some good summation of recommendations in their paper in 2014, although old, and the newest one, unfortunately. I think it's still really helpful and kind of went through a lot of the things we've already talked about, but sort of really maintaining that routine care, making sure that they've got their medications, that they're staying on their disease-modifying therapy, that they have identified a place that they can get emergency care for. If it's extended travel, might they need a hematologist abroad? So I had one patient that actually was going back home to India for several months. And we had identified through the ASH network somebody that had been interested in getting more extensive training. It was actually a blood bank doctor, but was fairly close to where she was going as a resource. And unfortunately, she actually ended up getting fairly sick from a complication during travel. And that person was able to actually care for her and communicate back with us to be able to get history and other pertinent information. So it was actually, even though it was abroad and it was in a very large region with only one specialist that was close by, it actually was a pretty effective strategy. Again, malaria prevention is important, especially for people that are traveling to those endemic countries. Vaccinations are very important, especially for preventions of infections. Preventing diarrheal illness and hypovolemia, so instructing patients to really hydrate well. In airplane travel, I really talk to patients about drink enough that you're getting up every couple of hours using the bathroom and moving around. And that sort of gives you the twofold, right? You're staying hydrated, preventing crisis, but you're also, preventing sort of that VTE risk. And then making sure that you have sort of that travel preparedness. So they talk about traveler's insurance and coverage of trip and cancellations and that sort of thing, which I think is really difficult. I think for people that have resources, that's awesome. That's great. I have had patients that have needed to cancel trips that due to illness that I've been able to successfully write letters for and provide documentation for. But those are just some other considerations with patients with travel. So that was a very brief overview. I don't know if we have time for questions, but thank you so much for letting me give this quick overview.
Thank you so much. I think we have around 5 minutes or so for questions before the case. I'm curious what others are doing because you mentioned the high altitude simulation test, and it hasn't necessarily been studied in sickle cell, but it is something that I perform more so for my patients who are anxious, and it's more to see would this person potentially benefit from oxygen on the airline? But I always will give my patients a caveat because I've had patients with normal high altitude tests and they still ended up developing a crisis with flying. So we always have to kind of give that disclaimer. But I'm curious of other institutions and how people are ordering that or have they even heard of it?
Good morning, everybody. Let me turn my video
Hi,
on.
Donna.
Hi, good morning. Oh, the lighting's bad, sorry.
No
What
worries.
is the high altitude test? I've not encountered that.
Yeah, so it's a procedure done in pulmonary or at least at our institution, it's performed by pulmonary, and it basically puts an individual under different oxygen concentrations, like 90% oxygenation, just to see how their body tolerates it. And if it would basically just clue in a suspicion if this person has any drops or intolerance based on their vitals or just symptomatically, then you would say that they would potentially benefit from oxygen. So I've had patients with tests that they did not tolerate, and those were ones like, okay, let's get you oxygen and coordinate that because not all airlines have oxygen. I don't know if United Airlines changed, but in the past they didn't, which was hard because it's very expensive to rent it otherwise. But it's a test. You should ask and see if it's available at your center. But it essentially would just check a patient's tolerance to low oxygen concentrations and kind of simulate what is happening inside an airplane.
You found that that's covered by insurance?
Yeah.
Okay, thanks.
We provide a travel letter for our patients, and it just allows, the TSA to let them bring in water. Sorry, my camera's not on.
No worries.
But and to make sure that they can take their medications with them on board. We don't let them, pack them in their suitcase.
Yeah, that's a big one, is I always telling patients to bring their medication in their carry-on because it's always when you don't have it is when you need it. One of my patients, she brings a heating pad on the airplane, which can plug in, which I don't know, it makes me think in the hospital, oh my God, we still have to get all of these things approved, but I hadn't thought of that. And I thought it was a very creative method and dressing in layers, things of that nature. Does anybody else have any questions or comments regarding traveling with sickle cell?
Yeah, I have a question. What diagnosis would you actually use to be able to do that altitude test? In the past, we've had patients who've traveled and, fortunately, they were able to afford getting their own oxygen from oxygen companies to take with them when they travel.
Yeah. Ashley, I don't know if you want to answer. I can say what I do and see if it's similar or different, just given the different
Yes.
states.
So in Maryland, so I have not done this in Philadelphia yet. And I've done it all of one time for a patient in Maryland for high altitude testing. I actually ended up using the sickle cell diagnosis code and actually got it approved that way.
Same with me. And I just put in the document in my clinic note, I'm just very detailed and state that patients traveling long distance and understanding that hypoxia can trigger blah, 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 and just put a good sentence that kind of covers that. But I do the same as sickle cell. D57.1. And Jennifer Houston just said we use it for patients with multi instances of acute chest or nocturnal hypoxia. That's true. That's a good one too.
But another question or something that just crossed my mind. If someone does not do well on the high altitude test, do you think there's other workup that we should be doing for them? Just
Yeah, I
in
mean, I
general.
think it depends on what the results are, but if there's anything that's suggestive of like restrictive lung disease or things of that nature, maybe you follow that up with a pulmonary function test if it seems like there's more beyond just the sickle cell contributing to the drop in oxygen.
Mhm.
Yeah. Awesome. Well, I am going to now switch gears and we're going to have Fadila come up to do a case report, case study. Thank you so much. I feel like we're hiring you for our monthly echo sessions with your cases. So as a reminder, if anybody has any cases that they want to present to this group, it's a fun way to just get different opinions and whatnot and see if anything's being overlooked. And if you're ever interested in doing a presentation and looping in a case as well, that's always an option. So with that, I will let Fadila kick it off.
Well, thank you so much. And this case is also possibly done thanks to Ashley. So Ashley, thank you for putting this together. I really appreciate it. So this patient is a 25-year-old female with hemoglobin SS disease. And just for background information, she was a patient who was struggling with pain, uncontrolled pain, no matter what we gave her. So we put her on chronic transfusions. She was doing excellent on chronic transfusions. And then once she felt good, didn't need pain medicine or anything, she stopped coming. And then the next time we saw her, she was in excruciating pain, went to one hospital, got discharged from there, came to us, ended up being admitted, got discharged, and then came back. This time she stayed for long and finally got discharged. So it's been like a lot of admissions for her for a short period, given she hasn't had one in a long time. And so this patient was also referred to Dr. Law. She hasn't been. So I'm trying to talk to her and see how we can get her there, at least so she can have a consult with a sickle cell expert to try, and probably somebody will talk some sense into her and her mom, so they will try to do the right thing. She has no primary care doctors. We've tried, and we're gonna keep on trying. And I think this time mom got it. She understands that her daughter needs the care, and she was trying to let her be independent. However, I don't think she's there yet. She still needs somebody to be behind pushing her. So no primary care. She came in with complaint of generalized body pains, the knees, the arm, and it was the right left, lower leg as well. So she usually takes oxycodone 10 milligram at home, which she hasn't really needed for months. So other medications she takes are listed there: Tylenol, hydroxyurea. She's only taking 500 milligrams per day. She can't tolerate anything more than 500 milligrams. That's why she's just there. But she hasn't really needed to take it because she was on the chronic transfusions. And she was discharged home on the 26th. Scroll down a little bit for me. Let's see. So when she left the hospital, her pain was like maybe 1 to 2. And she was on PCA pump for a long time at the hospital, along with the IV pushes, which we were able to manage to win her off of it. She does have a history of acute chest syndrome, now no psych history, transfusion, yes. And we don't have any antibodies yet, although we're worried about it for everybody who's on transfusion. And we did have blood for her, which she finally received on the 20th. It helped a lot with her coming back up. Vital signs are there. They are stable. No complaints there. Her baseline hemoglobin with transfusion was stabilized at 10 to 11. Before that, she was always low. White count 12.5, and the labs are there, MCV 79.3. And let me see, electrophoresis is right there. I believe this one is the one we did before she got the second blood, because she got 1 unit on the previous admission, and that's what really bumped her A up to 55. And by the time we gave her the second transfusion, this is where she was. BUN creatinine, nothing to worry about. Toxicology, positive oxycodone as expected. And the chest x-ray always came back with nothing to worry about. Let me see, scroll down for me some more. Scroll down, keep on going. Let's see what else is there. All right, so she doesn't live on her own, and I didn't know this, I thought she was still living with mom, but she lives on her own. And she likes to move around a lot. She travels a lot. She goes to places with her friends just to, hang out and have fun. And because she was doing well, she didn't have to worry about the pain. And one of the things that we noticed with her while she was admitted, although she got the 1 unit of blood, went home, since she's missed about 3 or 4 transfusions for her chronic transfusions, it wasn't really helpful that, she only got 1 unit because the medical team already at the time, and we didn't do the second unit because by the time we did the post-transfusion hemoglobin, it was like in the 9. So we left it alone. And she went home and came back. We noticed that she started dropping again, and the pain was out of control. So we decided to give her 2 more units with the plan for her to come back in 2 weeks to get another 2 units with phlebotomy for partial, so we can get her back on track. She is doing good, by the way, at this time. My only worry with her is that I know she was doing really well coming for the transfusion. Especially, we have to call her. Really, we really called her every month. This time we called her, she said, I'll call you back. She never did, everybody was crazy, busy, and we just kind of like forgot. So we have to like take some responsibility for that. And we just didn't call her for the last few months, so she missed the transfusion. I was worried about her. For patients who are on chronic transfusions like this, she's very young, and this seems to have been the only thing that's working for her at this time. So I'm worried about what's going to happen if she ended up developing some antibodies and, reach the point where she can be transfused anymore. One of the reasons why I was referring her to the hematologist to try and see if maybe she might be a candidate for one of the therapies that just came up, especially since she's an SS.
The gene therapy, you mean?
Gene therapy or bone marrow, whichever she decides to do.
Cool. That was my first thought too. I'm just curious for the, you said she couldn't tolerate anything higher than 500 milligrams of the hydroxyurea. What are the symptoms that prevent her from?
She's basically GI symptoms.
And you've tried doing like taking it at nighttime and sleeping through, and
she's one of those young ones, and she's gonna do what she thinks is best for her. If you tell her do this, she say, I'm not gonna try. Yeah.
It's hard. I can ask so many clarifying questions. So I will open up the floor first and see, does anybody have any clarifying questions based on this case? Because we have a 25-year-old with hemoglobin SS. She was on chronic transfusions for uncontrollable pain and responded really, really well, but she stopped it. And since stopping, she's had repeated admissions. She's on a low dose of hydroxyurea due to intolerance, and now trying to determine what the best path is for her, since the chronic exchanges were working well for her. And just from a medical history standpoint, I think you said she had acute chest and iron overload. Otherwise, organs function is doing great.
She's
So feel
not,
free to go off mute, ask any questions. Yeah.
sorry. No, that's okay. If she's not doing the transfusions, why do you think that she's going to be able to do the bone marrow and keep up with the appointments with this bone marrow or gene testing and keep up with the appointments?
So we are hoping that, with mom being there and getting back into the picture, because I think since she moved out and living on her own, that was like one of the things that I think has affected her, where she feel like she can make her own decisions and she's not making the right ones. With this last admission, her being in the hospital 3 times in a very short period, she is now determined, although that remains to be seen. She promised that she's gonna take this thing seriously now. She will do, follow the recommendations that we're giving her.
Videla, 2 questions. One, does she have any matched siblings that could be potential donors for her? And then the second question is community health worker resources, like has she been open to Kathy being engaged with her? I don't know where she lives.
She didn't want a community healthcare worker. Like I said, she thinks she got it. And she does have siblings, yes. She has siblings. She has, I think there's 5 of them. So I don't know if any one of them are willing to be tested, but the important thing for us is try to get her there at least to start the discussion with the expert and try to decide whether, she's even gonna explore that route.
Yeah, I think I don't know who had come, I think it was Sandra, maybe who had come off from a bone marrow transplant standpoint. So I think from a BMT, if she's not compliant with that entire regimen, being non-compliant with the bone marrow, obviously with graft versus host, that could kill you. So I was thinking when I was looking at this case, I was like, she actually could be a good gene therapy if that was an option for her, because she doesn't really have any. Her biggest issue is pain. She doesn't have organ failure, but it does require a commitment as well. So she's kind of used to the exchange process if she was open to it. But I kind of want to, based on your answer for the hydroxyurea, I'd want to dive deeper on that, because it sounds like she might be the type who doesn't want to take any medications and more of a holistic approach. And if that's the case, is she going to accept chemo potentially for the gene therapy itself? Has she been evaluated? Has anybody from your psychology or social worker just had a talk with her and just tried to see what her beliefs and her experiences and how it all comes?
I believe Jasmine might have talked to her before. Jasmine might have talked to her. I have to go back and see if there's any note on there. Other than that, she usually, does really good. She's hard-headed, but I think the whole thing is that mom is trying to let her take care of herself, be the adult and be able to do these things without her having to be behind her. And I just think that, from them being at Children's for so long, children baby them all the way to 22. So when they come to us, they still act like they're 14 and 15. They don't act like they're 22 years old. So I believe that she still needs the help from mom, and mom got it this time too. Mom talks to her, she listens. So if they had to go to consult and discuss this with Dr. Law or any hematologist, then they probably will have some perspective and decide whether she's gonna have to be serious. And I think she can do it. That's the thing. I believe that she can do it. She just needs to understand, how this is gonna benefit her in the long run.
I think you just answered it. You answered your own question. We just need to, because I think a lot of times with patients, when we just tell them what they need to do, it's very different than when you take the time to kind of paint the entire picture, because a lot of our patients are kind of just in survival mode and they're just trying to get to the next day. And it's hard for them to kind of see the bigger picture. And I think that you're literally what you just said kind of instill a little bit of hope and make her realize what, this is kind of inconvenient to do. And it's because patients don't want to be identified by their condition. And when you're on a chronic transfusion or chronic adacthy or just something regularly scheduled, it's a constant reminder that you're different and you have a problem that sometimes people, I mean, you think of your fight responses, trauma that will cause you to kind of retreat, which it sounds like she might be doing. But I think if you can highlight to her, like right now, this could be short term and we have certain options. Like a lot of times with my patients who don't like hydroxyurea, I basically say to them, like, right now, this is the best medication we have. In my own belief, I don't think hydroxyurea is going to be a lifelong medication. I think we're having a lot of advancements in science and technologies and treatments, but right now it's the best option that we have. And as soon as I say that and they realize like, oh, wait, I might not be taking this for the rest of my life, then all of a sudden it kind of like breaks off on a little bit of a shell or peels one piece of that onion layer back. But I would just let her know like all of the treatment landscape that's expanding and the different treatment options. And these are our best options right now. And we just want to make sure that you're going to be healthy and your organs are going to stay healthy and we're preventing complications. So when that next better, greater treatment option is available, you're going to be a good candidate and you're not going to be dealing with other complications. And maybe that would resonate. But I think a lot of people are kind of just in survival autopilot mode and they don't want to have a constant reminder of their condition. And especially at 25, that's at an age where you don't have enough life experience to fully grasp it. And it sounds like mom is trying to give her the independence and she's not fully ready, which could negatively impact her. But as her care team, that's where you can kind of step in, not you, but your team in general, to fill some of those gaps and empower her to kind of take control of her health.
Yeah.
I still think gene therapy, if she was open to it, I think, and if it's available, could be an interesting option for her because she doesn't have any issues. Or I mean, she has the iron overload, which will be easy to address if she's cured. When I say cure, obviously we're all in the same term.
Yeah, we had a little bit of talk about it, you know, and mom says she's gonna do a lot more research on it. But ultimately, I told them, you know, there's a lot of things that you might not understand, and you benefit from a consult and discuss this openly, get your questions answered. So they said they're gonna do
that. I do think, Fidela, I feel like if people met Kathy, they would be so receptive to her, right? Like the community health worker there, especially if she's gonna, I think starting with the consult, seeing what Dr. Law says, but like if she is eligible and wants to do gene therapy or BNT, that's gonna require her to go to Baltimore, which is far for her. So having that extra resource is just, I think it doesn't hurt anything. And like, you know, Kathy, the community health worker that works there is like, just a wonderful mothering sort of figure that I think would be just so great.
I think we didn't push it because she was doing so well on this thing, and we're like, okay, we'll just call her and remind her for the month to come in, and we've done that successfully. And she will come in when you call her, like, hey, you missed your transfusion appointment yesterday. You know, she just rescheduled it. There has been some time when she came in and we just cross-match her the same day and giving it to her, you know, because we don't want her to leave and forget to come back. But I do believe that at this point, that will be something that they will be open to, given the experience that they just had. And I think that mom also needs some help. So that will be something that we'll discuss at her follow-up.
And it seems like mom has a good influence on her daughter. So that could be an instance where you talk to mom separately and be like, I know you're trying to have independence and this is another support and resource that we can utilize that can take some of that work off of you, but also give her the support and the guidance that she needs.
That sounds good. Yeah.
Nice. So since this is a pretty consistent group, I just want to throw it out there. So next month, I think am I May? Maybe I'm June. I forget which month I'm doing. I'm doing leveraging social media to bridge health disparities, but I was also thinking of doing a presentation on integrative health or integrative patient care and kind of touching on Eastern and Western modalities. I have to kind of make both presentations. So is there a preference for the group here since a lot of you are kind of recurring attendees? Is there a preference on what topic you'd like me to do that month? Do you want to do social? I mean, social media is super interesting if that's something that you've kind of been into it and want to learn more. But if you're also interested in doing integrative approach towards patient care, I think that is also a fun topic. And if not, no opinions, I would just choose whatever my heart desires.
I think both are super important because, you know, we talk about talking at visits and handing out papers and, you know, sending messages through my chart, but the social media is where it's at for, especially like the one who's
getting info
today.
That's true. Cool. I'll stick to social media. Oh, we got to integrate it. I think I'll have to probably do both of them.
Yeah, but I think we like both of them if possible.
All right, we'll do. I'm just filling in the gaps where I can't find presenters. So again, if anybody wants to present, let us know. It's a really great opportunity. It's only 20, 25 minutes. So especially from a professional standpoint, like my first presentations were like 45 and 60 minutes and my anxiety was just through the roof. That I think this is a really nice intro for anybody who's just wants to get their foot wet. And then I think just from the case standpoint, Fidelia, you're amazing. Thank you so much. And Ashley too, for all of your help making those cases. But if you wanted to present and kind of tie in a case into that presentation, kind of highlighting a patient for whatever topic is, then that would be great.
Thank you. Thank you so much.
Well, thank you for that case. Thank you, Ashley, for the presentation as well. I think connecting with the community health worker, speaking with mom, speaking with the patient, kind of letting her realize that there's a bigger picture in her life, that hydroxyurea, chronic transfusions doesn't have to be her entire life, and kind of go over the gene therapy and bone marrow. I think gene therapy, just given her track record, might be a little bit more safe given the risks. But I think it sounds like you have a great team that will be able to handle this. So thank you for that case. Does anybody have any questions or comments before we wrap up our session today? Sonia has put the link in for your CEUs. Again, as a reminder, if you have anybody in high school, college, graduate school, vocational training, etc., with sickle cell, we do have the scholarships. The deadline again is May 1st. So I only have a few applicants. So honestly, anybody who applies has a very good chance of winning that. So please spread the word. And with that, I hope everybody has a wonderful Tuesday and a wonderful week.
Hang on one second. Did you say scholarship for school?
Yeah, there's two different scholarships. One is for high school students who have demonstrated just an impact on their community, or I called it a future health advocate scholarship. And then the other one is for individuals with sickle cell in college, advancing their degree if they're in vocational training. We know that higher education is associated with better health outcomes. So I'm just trying to tackle different root causes towards health disparities through the nonprofit.
Yeah, well, I have one of my patients who is really looking into going into nursing school. So I don't know if she'll be a good candidate for that.
Yeah, so I just put my link in the website, I should say, there. And if she goes, there's a tab for the scholarships. But otherwise, I'll get your email from Sonia or Ashley, and I can send you the link for her.
Sounds
And
good.
I'll send it out in the follow-up email. I'll include the scholarship information as well.
Thank you
I'm going to give
much.
you a link to just awesome. Thank you guys. I really appreciate your support for me. It means a lot. Great. Well, we will see you next month then. And then Sonia will send all of the flyers that she had, because that one from May 7th to May 8th, that virtual one from Sloan Kettering, seems like a nice opportunity for anybody interested as well. Don't forget to get your CEUs for this course. And with that, I hope everybody has a wonderful week, and we'll see you soon. Bye. Take care.